Okay, everybody, welcome to our February EduCast. Super excited to have you all here for a really exciting lineup. I'm Renee DeVersdal. I'm the Chief Medical Officer here for Vave, and I also am a hospitalist and medical educator, director of POCUS at Oregon Health and Science University. And this morning I was actually up teaching my med students on the Hill, so I took the liberty of wearing my scrubs and my Vave swag jacket for this EduCast, but maybe next time I'll dress up more for you. So we have three fantastic speakers. I really like to advertise and get the voices of not just one specialty. So today we have one emergency medicine doc, and we have two internal medicine docs as well. So our emergency medicine physician actually was stuck on shift today, but what we did was we interviewed in advance. And so I'm going to pre-introduce, and then you're going to see our interview. So the first person that joined me earlier was Dr. Vave Lobo, and she is the director of point of care ultrasound at Stanford Emergency Medicine. And she's also the co-director of system-wide ultrasound at Stanford. She's a medical educator, researcher, and really considered to be a leader of the field in POCUS. She's been on the board for ASAP EUS newsletter, Society of Clinical Ultrasound Fellowships. She just recently in October received the Contribution to Section Award by ACP-EUS and is published, as we're going to hear about. The other fun fact I learned about her in her bio is that she was born and raised in Kuwait and is a proud immigrant to the United States. And so it was really neat to get to hear more about her and her story. So I'm going to play her video. Unfortunately, she won't be here for Q&A at the end, but I'm going to compile questions, and you also can find her on Twitter. So first up is Dr. Lobo.
Okay, well, thank you, Dr. Lobo, for joining me today. I appreciate your time, knowing that you're on shift as we're actually playing this for people. So the first thing I wanted to hear from you is your interest or your background in POCUS. How did your interest get piqued, and what's kind of led you to where you are today?
Well, it's a pleasure to be here, Renee. Thanks for the invite. It's actually I graduated about 10 years or so ago from residency, and I wasn't fortunate at the time to go to a place that had a ton of point of care ultrasound in our residency training. So I learned some of it kind of on my own, and we had a couple of faculty, who did a little bit of it. But I sort of just grew a natural interest in it over the 3 years, and I found myself in the third year kind of wanting more. And I was sort of like, okay, I could take a couple courses, or I could, go online and take some things. But I, at that point, also knew that I kind of wanted a career in academics, most likely. And so I kind of just put the two together, and I said, well, I really want to learn more ultrasound because I think it's really good for patient care. And that was really the only ideal. And because I didn't feel like I was adequately trained in it at the time, I wanted to go out and find a fellowship. And so that's kind of how I made those first steps into choosing a fellowship and kind of setting this path of this career path for myself in point of care ultrasound. And as soon as I kind of took that step, and I went to an amazing program at the time, with Lale Garbagian and Sarah Williams, who were my fellowship directors at Stanford. I, just fell in love with all aspects of point of care ultrasound, the administrative part, the research part, the education part. And I knew that this was my home and this is my people. And, the subject matter was just exploding at the time. And it was just a very exciting time to be in that space. And I sort of kind of just took it from there. So that's sort of how it happened. And 10 years later, I'm still at Stanford. And now I'm fortunate to direct the program.
That's amazing. Well, the other days we were emailing, and I was like, hey, I would love it if you would come on this EduCast with us. And I said the thing I'd probably be asking about was your most impactful research. And you actually, what you sent me, which I'll have you tell everybody about how it came to be, the inspiration behind it. But you sent me this paper that just that morning I had been quoting to my med student on image review.
Thanks for using it. It's definitely, so the paper we're talking about is a FAST paper that I did that showed or studied where free fluid is collected the most, or where do you see it the most when you're doing your FAST, and where it's most sensitive to be found. And so we found that it was around the caudal tip of the liver edge in the right upper quadrant view of your FAST exam. And this was a study that I did. It was my fellowship project, actually. So it's going back a couple years. And, I I wasn't trained in research. I went to a very clinical program for residency. I did a couple of small scholarly projects to kind of checkbox the requirements, but I didn't find something, or I wasn't really drawn to anything more than that. And so when I came to fellowship, and you have to do an academic project, I was sort of like, okay, what should I do? And one of the things that's, our program at Stanford, we do, just in any ultrasound program, there's a lot of QA that happens. And so we do weekly QAs. And as a fellow, you're there for all of them. And I would review, I don't know, 100 fast exams or something like that with our faculty every week. And it was something that we just organically started to notice, right? We just noticed that for most of the fasts that were missed, it was because we didn't get a good view of that caudal tip, or it was a quick, hot second view and there was no fanning in that region and we kind of missed it. And then when they get the CAT scan or some other study later on, you see that there was a ton of fluid around that tip. And so and sometimes when we caught it early enough, we would notice that it was only in that space and it actually didn't ascend into Morrison's pouch yet. So it was very, just a subjective anecdotal thing at the time that we noticed. And so, we just, Lale Garbagan, who was my fellowship director and I at the time, was like, this would be really interesting to study. And so we started looking into it. And we always, I just organically always would tell the residents when I was teaching that you should look at both spaces. But I realized that it wasn't studied really at the time. And so we thought this would be a great project. And we had data going back like 10 years or almost 10 years, even up at that time, for images that were saved and archived. And I had charts that I could pull up. So we had a pretty big database that I could look through. And for our level 1 trauma center, we do a ton of fast exams, every day. And so it's, we had all the stuff that I needed to get this done. And so that's kind of how the retrospective study came to be. And, right enough, we were able to show that truly is a significant finding and something that we should alter, because I too was, the books that I read always preached Morrison's pouch. That's where you need to look. Yeah. And I realized that might not always be true. And so we were able to, in my humble opinion, able to kind of study it and say, okay, that's might be the best thing to teach. And maybe we should be teaching that we should look at the caudal tip first. And so since then, now I have the evidence backed to teach my residents that and go out and say that. And I can cite the paper. And, there have been some follow-up studies from other people since then. And so it's been nice to see that grow and kind of make a small change in something that a lot of people knew, but again, that's where the power of research comes, because now once it's studied, it's accepted and proven, I guess.
Yeah, I love it. I think it's, sometimes things make sense. So people would say, it's easy to say, well, Morrison's pouch is the most dependent place in the supine patient. So of course fluid would go there first. And so a lot of times in medicine, I feel like we kind of take leaps just because it makes sense, not because it's been studied. And then anecdotally, as an internist, I call it the fluid assessment sans trauma because I'm a nerd. But a lot of my cirrhotic patients, that's where I see the fluid is up there around the liver tip. I have no idea if it has to do with the nodular regeneration and, whatever. I can hand wave a lot, but I definitely notice it there more. And so, yeah, being able to kind of point to data and not just say like it's me randomly on the wards, it's very cool.
Well, it's the same thing. I tell my residents all the time, and it's been amazing now that we've been sort of preaching this now for the last however many years. When residents, it's so cool because they automatically now, especially the last 4, 5, 6 year residents, that's just what they've learned. They've just learned to do that, and so
not in question.
Right. It's not even it's like just the way it is, kind of how we learned, that Morrison's pouch was it initially. And so it is cool to see that evolution and how we progress and, advance our field in that sense. And, and even till today, I'm always amazed when I do see a little bit of fluid around that tip. And then all you do is just fan a little bit and, you'll see the depth of that fluid. And so, a little fluid's a lot of fluid. And I tell that to my residents all the time. But it's, it's one of those studies where we can make a difference, and it really will change patient care. And so it's important.
Yeah, for sure. Well, I love it. And it was just the perfect timing when I had heard about it. One thing I would love for you to be able to do is to tell us about anything cool or upcoming, or, kind of what you're working on now. What should we be on the lookout for?
So, since then, so we've done a couple of studies following that. clinically, we did some studies with, we did tamponade. We've done, I think I've focused a little bit more on educational studies in the last couple of years. Particularly the one that comes to mind is, resident assessments and even some medical student assessments, and, not just teaching, but then assessing, because that's more important in a lot of ways. And so the last one I can tell you about that we just actually got in was so I don't know if you know the term mastery learning is really what it is. It's mastery learning. And so mastery learning is this technique where you teach a resident, or you teach your learner in a very methodical way. So you kind of come up with you come up with like a checklist almost of, this is the ideal way to do this particular exam. And it could be a procedure, it could be an ultrasound exam, whatever technique or whatever skill you're trying to teach them. And you come up with a checklist with a bunch of different experts in the field. And then you go ahead and you have them, teach your residents using that method, where they need to hit all of those boxes, like 90% or a really high success rate in order to pass it. And so we've adopted that method of learning, and it's been studied and it's been used widely in other fields as well. And so we've been adopting that to teach ultrasound exams actually in the past couple of years at Stanford. And other institutions, I know other EM programs have used it as well. But we did it for the FAST exam. We studied it when we did it for that, and to show, that does this make an impact as far as their retention or their skill or anything like that. And we showed that it was superior in some ways. So it's just a better way to teach. And then we just recently did it for the serratus anterior block and then studied that as well, which was this past year. So it's been cool because it's been a different, I'm fortunate to be surrounded by a lot of really great educators at Stanford. We have some really good education folks, research folks who do a lot in education, and I have some resources there. And so we've been able to collaborate with them and study a lot of these. And then, of course, last year was the year of COVID, and still, I guess, in a lot of ways. And I think you've had Dr. Kumar is going to speak more to it, but I was fortunate to collaborate with him on his COVID lung ultrasound study as well. It was a very cool, well-designed study that we got a couple of centers involved, and it was really, I got to participate, and we got to send, some data from the ER at Stanford as well. And so that was really cool. And I was glad to kind of participate and contribute early to that.
Yeah. I loved seeing the varied settings there. A lot of times it's just one setting. And so, yeah, that to me was especially cool. So yeah, we are going to hear more about that just very, very shortly. And I think it's so, I came up through the education lens. Like I love med ed, and had, interviewed at Stanford with Dr. Kelly Skeff, and there's the incredible, education programs there. And so you're definitely at a really remarkable place to do the education research. And I think it's so important for us because students loving it is kind of a given. We're really lucky to teach a super fun, cool thing. But do we do it well enough? Does it, translate to patient care, these other things? So I'm really like the ed research component as well. So
the other thing I like about ed research, which was kind of surprising to me, honestly, because it wasn't something that I thought about before getting into it, is we have a fellowship, right? So we have 2 to 4 fellows, honestly, every year, and they all have to do projects. And up until that point, if you think of someone's career, they've been involved in academics, right? You go to med school, you go to residency, you're surrounded by educators. And so a lot of us, or a lot of young fellows, kind of had this natural tendency or comfortableness with education, and they tend to go in that direction, especially once they do their fellowship. And so ed research, I've realized, has become a very natural, easy way for people to start their research interest, and because they understand it, they've been part of it as learners, if not in any other capacity. And even for me, it's the most important piece, I think, for research is having like really solid mentors. A lot of us, don't come knowing a lot of research. We're so focused on the clinical aspect of our training, right? And so research doesn't necessarily come naturally to all of us, but it's so important, I think. And so I know I was fortunate to have some really awesome mentors early on with my projects that kind of put that seed in, people that I can identify. And so I think education now has lent itself to me because I can easily be a mentor for somebody in that space. And when I see our young fellows, they just gravitate towards it, and because they understand it, and then from there they can build on that knowledge to kind of do things far. Some of my old past fellows who graduated have just gone out and done some incredible things, and it's cool to see where it all started. And often education is where it starts.
Yeah, it's kind of the easy, it's not easy. It's actually really hard to assess, but it's an easy interest because I agree, we're doing it. It makes sense. So cool. Okay. Well, thank you so much. So I'm going to give the audience, at the end of this, I'll have contact information for people to reach out. And I hope that your shift goes super well and you do some ultrasound while we're talking about ultrasound. So thanks so much for your time.
Thank you for having me. It was really nice to be here and to speak with you. Congrats on all that you've done as well at Wave, and I'm excited to see what comes out next.
So next up, I was able to pre-record again with Dr. Andrekumar. He was actually teaching medical students just before this, and so we weren't positive he was going to get on before the Q&A. So he's going to be here for live Q&A, but we pre-recorded, so we made sure he could do his due diligence teaching his telemedicine examinations, very important in the days of COVID. So Dr. Andrekumar is has both MD and MED degrees, and he's a clinical assistant professor of internal medicine at Stanford. So he's a practicing hospitalist. We'll hear about his work. And he's very passionate about POCUS. And most recently, we had come across and learned about him using our probe in this amazing research. And so I was like, that's perfect. I would love to hear more about it. And really what triggered, how did you come to think about this? In terms of other service work, he's the co-president for the Society of Hospital Medicine in the Bay Area chapter. And he's also the director of the Stanford Internal Medicine Procedure Service, and also teaches at the Society of Hospital Medicine's POCUS certification course there in the Bay Area. I asked him for a fun fact, and I learned he was a state champion in yo-yoing. Boom, mind blown. So with that, we're going to move on to something a little bit less exciting than yo-yoing, but more near and dear to my heart. So here's his vid, and we'll get Q&A with him at the end. And I should have mentioned earlier, please do, whatever platform you're watching this on, please do type in questions, because we'll go through them at the end, and it would be wonderful to hear from you, whatever platform you're on.
So I've been using point-of-care ultrasound in my practice for over 6 years now. And when the COVID-19 pandemic really hit us, that really became a focus for my clinical practice, but also my research endeavors as well. And how I really became interested in this was I was reading an article on Vox in March 2020 about the COVID-19 pandemic and the outbreak in Wuhan, China. And this particular photo really struck me of the impact COVID-19 can have on our healthcare system in terms of our infrastructure and our resources. When I look at this picture, I see a patient attempting to get a CT scan, multiple providers in the room using PPE, fully gowned up. There's a technician, actually, or a radiologist perhaps, in the background in the back room, awaiting to interpret the scan. I don't know what the ventilation is in this room, but you can see in the back there are a couple of windows open. And you would assume that this particular CT scanner is one of the few CT scanners available in the entire hospital, if this is a hospital setting. And if there are patients who do not have COVID-19 and they need to get a CT scan, the process involved to potentially decontaminate this entire room so they're not exposed is quite an arduous task. Or if this is just the one CT scan in the hospital, it's going to be tied up just for COVID if the agreement is not to decontaminate it. And so I was thinking to myself, oh my gosh, this is just such a resource intensive process to image someone's lungs. And knowing that point of care ultrasound has the potential to identify some of the cardiac and pulmonary complications from COVID-19 made me really start thinking about how I can implement it in my clinical practice and how we can possibly research it. And one of the things you never really forget is the first time you go into a COVID-19 patient room. I remember the first time I was in a room, I brought with me one of those giant cart-based machines to actually scan the patient. And needless to say, it was essentially a disaster. I brought the machine, I covered it up, I scanned the patient, but then afterwards I realized there's so much that I have to do in terms of decontamination. The next time I went in, I brought another machine with me, a smaller portable one, but it had a cord. And this was around the time that we were hearing about COVID-19 persisting on surfaces, for instance, plastic persisting up to 72 hours. And I was really hesitant at that time to contaminate potentially my phone or even a cord related to one of my devices. And so that being said, I had in the past been in a partnership with Vave Health to help promote and develop their ultrasound. And I thought this is a fantastic opportunity actually to use this device in a time of great need, but also use it in a manner that's very safe. And that's when I really started jumping into using Vave as my sort of go-to ultrasound, if you will, for COVID-19 patients. My sort of protocol now is I will generally wrap the ultrasound itself in some sort of barrier, and then my phone, I either will use a specimen bag or I actually use a sandwich bag because I find that still protects it very well, and the screen is able to still detect my fingerprint even with a glove. And that's usually how I've been scanning now for, gosh, these last 10 months. I'm showing here a scan I collected from a COVID-19 patient on the left and comparing it to a scan on the right, which is a normal lung ultrasound. And the things that really stick out to me when I'm doing these scans is just the abundance of B lines. The pleura itself looks very thickened. There's often what's called a subpleural consolidation associated with it. Lately, we've been studying lung ultrasound and its predictive utility for patient outcomes with COVID-19. The first study, which is in preprint and hopefully soon to be published, looks at the predictive utility of these findings in patients who are hospitalized. And essentially what we find is that particularly B lines and subpleural consolidations expose a patient to about a 3 to 4 time greater odds of requiring an ICU admission during their hospitalization. That being said, some providers may not feel very comfortable with lung ultrasound, particularly with more specific findings such as what I've discussed. And another important study we've really looked at is the first of its kind, really, is to look at inter-rater reliability of these lung ultrasound findings, particularly for COVID-19. And this study, looking at various probes across various users and different experience levels, we find that the main findings from this previous study I mentioned have generally pretty good inter-rater reliability across multiple settings and across patients who are hospitalized with COVID-19. And I think this represents a very exciting point for using POCUS in the risk stratification and potential understanding of the long-term consequences of COVID-19. And that's where we are currently with our research efforts. It's a joint study with UCSF, Stanford, and 2 smaller hospitals that we are working with in partnership to really understand how we can use point-of-care ultrasound to understand COVID-19, its effects on the lungs, and potentially predict how our patients are going to.
So I love that story from Andre, hearing just the observations and the thought process and leading all the way into how you set about creating this multi-site study. Super fantastic. Some of y'all better send in some questions for him at the end because I want to hear more. So next, we're going to skip over. I'm going to pull up Jamie or Dr. Galen here. So we are now live. So I'm going to introduce him live since we didn't pre-record this one. So we're giving you a smorgasbord of approaches here. So Dr. Benjamin, aka Jamie Galen, is the director of ultrasound and procedure training, as well as an associate program director of the internal medicine program at the Einstein Montefiore Internal Medicine Center, internal medicine residency program. So he, in 2015, received a Sharon Silbinger Faculty Teaching Award for the Einstein residents. He's led literally hundreds of resident teaching conferences and has done a lot of work on formalizing curricula for POCUS and procedures. He's published a great deal and is very passionate about quality improvement with POCUS. I've taught with him a ton at Society of Hospital Medicine, ACP, other places, and he's co-authored nearly 50 articles in peer-reviewed journals. And I asked Jamie for his fun fact, and we decided to go with the fact that he coined and introduced a lot of us to the term erythema probosum, especially when you're referring to the subxiphoid cardiac view. When our the learners that are like this, like, white knuckling it, and you have to peel the fingers off. So that was coined via Jamie. You can tell he's a guy with bow ties. Erythema probosum. Thank you for that one. And now I'm going to switch over to you and your slides, and we look forward to hearing more about you and your POCUS journey.
Dr. Verstal, thank you so much for having me.
You should be live. Let me maximize the screen for you. Okay.
Thank you so much. I am a dad, so I have a license to make a joke of like erythema probosum. Don't push too hard with the probe. It can cause redness on the skin. Thank you again for having me. It was great to hear the prior talks, especially Dr. Lobo's perspective from emergency medicine. It brought me back to when I first encountered point-of-care ultrasound in the emergency room at Yale New Haven Hospital when I was a resident, working with Chris Moore and Rachel Liu and some other pioneers. So it really reminds me of how interdisciplinary this field is. So I want to start by sharing with you just a couple quick clinical cases. I know we're here to talk about research, but we're all in love with point-of-care ultrasound because it's helped us take better care of patients by letting us make quick determinations and diagnoses at the bedside. This is a case I'll never forget. The first time I saw a right heart thrombus in a patient I wasn't suspecting venous thromboembolism. You can see the clot in transit there in the IVC on the left and in the right atrium on the right. Another case that I saw more recently on the next slide that reminds me of how POCUS is such a valuable tool in the hands of trained users. This is a patient who is in cardiac arrest from tamponade, and you see a large pericardial effusion. The clip is interrupted by chest compressions, but this reveals the cause of a cardiac arrest. And ultrasound was life-saving here to assist in ultrasound-guided pericardiocentesis, which proved life-saving, and the patient walked out of the hospital. Getting into some of the topics today about research interest, there's a lot that ultrasound can be used for in terms of quality improvement. And I say, research, really, I mean quality improvement evaluations that include looking at novel ways to design quality improvement initiatives. And so those have to be studied, and that's bordering on what's called like quality improvement research. Quality improvement can be distinct from research, but a very important area is central line associated bloodstream infections. So it's very costly. Over $3 billion the last time I checked is an important issue for hospitalized patients because difficult venous access is often addressed with central lines that might have another solution. So the central lines include central venous catheters and PICC lines, but these are invasive tools. They're costly. They take time to place. They're also potentially harmful. Patients may have side effects from invasive lines, risks that are rare, but include bleeding, arterial puncture, hematoma, and air embolism or arrhythmia. So we noticed that ultrasound-guided IV was a very well-established tool in many other areas of the hospital, emergency medicine, critical care, but it hadn't been studied in hospital medicine or in patients on the hospital wards. And so we looked to try to see if ultrasound would reduce central line rates on the floors, and our hypothesis was that it would. So we started out looking at a small study with a single user, that was me, doing ultrasound-guided IV on patients who were unable to get IV access by the traditional technique. This was using a handheld ultrasound, And in a small pilot, there was a trend towards reduction in central line use when this tool was deployed in the hospital wards. And so clicking through here, this study was on a medical ward for 3 months and included a single user and had a handheld ultrasound, like I mentioned. But the algorithm here, I think, shown as a trend towards reduction in central line use was not really generalizable because the user, was a single user, and it didn't quite show the impact we had thought that it could. And so we moved on to another project. I want to tell you about a bigger study where we had nursing collaboration. And this is, again, such a great area for point-of-care ultrasound, working across fields, not just and medical fields, but working with nursing. We trained a floor of nurses to use ultrasound. They're already experts at placing IVs, so learning ultrasound-guided IV was something they were excited to do. And both day and night shift of nurses were trained over a 10-month study period. We had a cart-based device for this study, but we were able to develop a curriculum for the nurses and also allow them free access to use the machine when they needed, which is much more broadly applied than a single MD user. They placed almost 100 ultrasound-guided IVs in this study period, and we were able to demonstrate a reduction in the central line use and midline catheters as well on the floor. This is a little bit of a busy slide. On the left, you see the intervention unit where this is a C-type statistical process control chart, so kind of a standard for quality improvement research, looking at the rates of PICS and midline. And so if you look on the left, the dark line in the middle of the graph is the mean of the number of catheters that were placed each month. And when the study is initiated, there's a dip in the central line use that reaches what's called special cause, where the number of those catheters is below the mean before the intervention. And that dip is in the left. When the study period, the rates of central line use on that floor reverted back to the prior use. And so that further supported the impact of this tool on reducing the use of the invasive means of venous access. The graph on the right is a comparison unit. So this study was published in BMJ Quality and Safety in 2019. It really supported the hypothesis that we had that this tool could be very useful for a very specific application in hospitalized patients. I think that's a lot of the research I wanted to talk about for now. I do want to put out just the future directions here would be to make this tool more broadly available for nursing curriculum, the training and equipment, as well as quality assurance and further quality improvement would be necessary for this to become standard of care in the hospital wards. I do need to put a plug out for the POCUS journal. I'm a co-editor in chief of the only free open access, free to publish, free to read journal for point-of-care ultrasound that spans every medical subspecialty and discipline that uses ultrasound. So I encourage you all to take a look at this free journal, take a look at the Twitter feed and the website, and also submit your cases and research going forward to our publication. I think I was going to tell you a little bit who's involved in this the journal, but in the interest of time, we can probably click through and just take my word for it that it's a great team. The editorial board is from a lot of different fields, including cardiology and anesthesia and emergency medicine and pulmonary and critical care, internal medicine. So it's a great lineup. Thanks again to Renee and to Vave for letting me share with you some of the quality improvement work I've done and to be here today with you. So thanks again.
at the very end, guys, remind me to go forward one slide because I'm super excited about the EduCast for March of, I can't remember the date, but March of 2021 is going to be another fantastic one. So in the meantime, though, I would love to get questions from our audience and from anyone else. Getting the echo again. Let me kill my audio and then come right back. So Jamie, what would you say, the POCUS journal's very cool. And what are you kind of like most proud of? Or what made you say, you know what, I want to take on a bunch more work that like, I'm not going to get paid for? You know, it's like P&T, which is awesome, promotion and tenure. It's great. But like, what made you passionate about that to want to lean in?
Some of the examples highlighted the speakers, you know, really reminds me of how much work still needs to be done for this field. I think as POCUS users, we know that there are applications that we take for granted have been either proven or are acceptable or standard of care. But there's so many questions. I think Dr. Lobo's example of the revising the what was an assumption about the FAST exam that where fluid might most be seen, the most sensitive location for fluid and trauma. I mean, that's such an important question and to study systematically. So I think that being a part of the bigger mission here is to really define going forward what the standard of research methods and the methodologies for evaluating point of care ultrasound at the bedside, whether it's as a diagnostic tool, you know, who the user is, and defining the right way to evaluate applications so that it can be more broadly applied and that we can convince the folks that don't yet, you know, see the power and efficiency and the safety and the benefit of point of care ultrasound, that we can convince them, you know, and continue to legitimize our use of this tool at the bedside, and to be a part of that discussion and help others have a venue for it is what really, you know, inspired me to join the journal and be on that end of it.
Yeah, absolutely. Convincing the haters is a fantastic reason. We all are trying to do it. And also, I think I'll give just on a personal pitch. So one of my med students had done a really great scholarly project. She'd done a survey. She had gone out there, pounded the pavement with clinicians, asked about barriers and facilitators to point of care ultrasound. But it was maybe 40 doctors from Oregon alone. And so, but she was able to get it out there via the POCUS journal, because a lot of they really are common. When other people read it, they're like, well, of course, this is it. But if we weren't able to have that voice, and she also got to put that on her CV and her ERAS application, and she's now, she's now doing great at a great IM residency, and that helped. Mm-hmm. So Andre, so speaking of convincing the haters, again, I loved your inter-rater reliability study about the COVID findings, because that's something that people really, I feel like they come back at us a lot. Like, how do you know people can do this? How do you know they do it well enough? How do you know it compares? And we're like, well, now we have something for the COVID and stuff. And so if you have any other reflections, feel free, since I cut you off with your audio. But I love that study, and I think it's really fantastic, and want you to have time to talk about any reflections or any of your other research that you're really passionate about.
And thank you for having me, and apologies earlier for my audio. When I think about inter-rater reliability for POCUS, that is a very common criticism that's raised, not just for instance, COVID, but in a broader sense, thinking about all things POCUS. And when we're talking about the haters, for instance, and increasing the standing that POCUS really has, not just in our fields, but really to the broader medical community, that's often a criticism that is raised. I'm really encouraged to now see a lot of research related to inter-rater reliability for things such as lung ultrasound, assessment of central venous pressure with the IVC, assessment of left ventricular systolic function. And I think as time goes on and more researchers do these studies, which are super important and must be done, it's only just going to establish POCUS even farther. I know there are so many people here that feel really strongly about it. It's convincing other people about it. And this is how we're going to do it.
Yeah, absolutely. Could not agree more. I think I joked around, so I started pounding the pavement, following around the ER kids, trying to get internal, the 4 other internists doing it, like almost 9 years ago now. And just the kind of, especially with internal medicine, we're very cerebral and like, no, show me the randomized controlled trials. And I love it. The EM folks are like, where's the trial about parachutes saving lives? Like, that's one of my favorite retorts. And Jamie, the case about that pericardial tamponade, like, I remember you texting me about that because we blogged about POCUS enabled never diagnostic events, things that should never happen. I can turn on my probe and rule out tamponade in like literally 3 seconds. So it's just, so clearly we're preaching to the choir, but that's why I really enjoy having experts like yourselves on with us to try to help spread the word. And that research can be fun. I loved Vavetta's points about education research. All of us love teaching it, but it's great to help prove that we're gaining competency. That's kind of the holy grail that we're all working on, the demonstration of it. But I will quit rambling. We do have a question from the Vave Health Twitter. And so someone asked, is there value to a workflow where raw ultrasound data is captured in a clinical environment, but is then post-processed later for enhancing the diagnostic information? I think in general, I'll just throw out that, like, I'm sure that there is. There have been, as a company, I will tell you, this is like the Vave answer, is that there's a cloud, right? But there's 100% the ability to bypass the cloud, because that was a really hot topic a couple of years ago when certain vendors were like, nope, your data goes through my cloud or it goes nowhere. And so, yes, data is raw data is a huge, huge topic. Artificial intelligence, all of these things. But I will answer that in a backwards way by saying with Vave, you 100% can have the data go straight to your impacts, QPAC, whatever. I shouldn't use brand names. So your own hospital servers, no middleman. Okay. Any other questions out there on the Twitter sphere?
I just want to add to one point you made about looking back over the way that ultrasound has shaped medicine at the bedside. Procedures are a really good example where a central line placed without ultrasound today would be unthinkable. But that was not the case 10 or 15 years ago. And so I think as the researchers like Dr. Kumar and really demonstrate that we can make diagnostic decisions safely at the bedside using point-of-care ultrasound, that the way that's a given, that's only a matter of time before it's a given that a medicine intern can rule out hydronephrosis at the bedside or make quick, goal-directed binary determinations easily. It'll just be, I think, a part of physical examination. But the bar is higher now than when the stethoscope first came out. So we have a lot of work that's still to do.
Yeah, so I agree. I feel like the bar has been raised. We're no longer able to say, but you can see it, it performs better, et cetera. Like, we have to prove it, which is why it was so fantastic to have you guys and do the previous conversation with Vavetta. So we will cut it off unless I get more audience questions. Really value your time in speaking with me and sharing. It's super exciting. So check out these guys' work. And also Vavetta is at Vavetta Lobo, Viveta Lobo on Twitter. You can also, like, Vave will be tweeting the stuff. You can follow me anytime and email me, and I'm happy to answer any questions. So it's been rad seeing you all. Thanks for being here, and have a good evening.
Thanks so much for having me.
Thank you.